All right, so bone neoplasm. Right, so anyway, let's go. So bone neoplasm, okay? It can be benign versus malignant, right? Like any cancer would be, any neoplasm. We could have primary versus metastatic. Now, here's one thing you need to understand. Any bone neoplasm, any bone cancer, most of it is not from bone itself. It came from someplace else. So here's the thing you need to think about. If someone has bone cancer and they're just being newly diagnosed, they're going to be looking elsewhere for another source. Can it come from bone itself? It can. But most of them are going to come from some other place, and it metastasized to bone. Where are they going to be looking? Kidney, breast, thyroid, lung, prostate. You see how to put it together? Okay? Signs and symptoms, pain, enlargement at that site, and also where the cancer is in the bone, that's also the weakest spot, so they get a lot of fractures during that, at that spot too. Okay? Benign is more common. That's a good thing. Doesn't mean all of them are benign. All right? But benign is common. Malignant is more in the elderly. But there are children with bone cancer, malignant cancer. Okay? 80% of bone cancers, okay, bone tumors for that matter, primary bone tumors, occur in either the distal femur or the proximal end of the tibia or fibula. So where are we looking at? You're taking all that, it's all blah, 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 right? Well, you're looking at what? The knee area. You want to memorize that, or you want to cut to the chase and say the knee area is where it's going to be. It's either the proximal end of the tibia or fibula or the distal end. That's the knee. So that's what I'm saying. You've got to, don't worry about all the minutiae over there. Understand the area. That's what you're going to be looking at. Okay? There's 4 types. Now keep in mind, leukemias are from bone marrow too, but there's 4 types excluding the leukemias. They come from certain origins, either the bone itself, cartilage, fibrous area, and there's a group of miscellaneous. So I just put a few things on here so you can see what's going on. If it's coming from bone origin, you're thinking of osteoma, right? And that's a benign tumor, as we did the nomenclature of cancers. It's benign. It's usually found in the skull. God bless you. But we also have osteosarcoma. Osteosarcoma, this is the most common primary bone cancer. Okay? It occurs in the metaphyses, right? In the area where the growth plate is, between the epiphyses and the diaphyses. 75% of these occur under 20 years old, teenagers. Okay? Keep in mind, we talked about Paget's disease. One of the complications we're scared about with Paget's disease, and that's why we need to diagnose it early, is that 1% of people with Paget's disease end up having osteosarcoma. Okay? 20% will spread to the lungs. And there's a 66 cure rate in stage 3 at the time of diagnosis. All right? So that's just a couple of bone origin ones. For cartilage, chondrosarcoma. If you see sarcoma, you know it's malignant, right? We did the nomenclatures. All right? This is usually found in the vertebrae, pelvis, and ribs. We also have fibrous origin, and we could have a fibrous dysplasia. That's benign. Dysplasia, it can become cancerous, and it usually causes a disfigurement. It happens in the skull. You start seeing a big bulge happening, something that's changing over there. And we also have fibrosarcoma. Again, sarcoma, malignant. Okay? Then we have a group of like miscellaneous bone cancers. There's something called aneurysmal bone cyst. It's a cyst. It's not really a tumor per se. A cyst is kind of like a bag of fluid, a balloon that's filled with fluid. And this balloon can be very big. In this case, this cyst is actually filled with blood. Okay? But it forms like a tumor-like mass. So it's something that we could, we don't know what causes it, but if someone's got a bump there, we need to see what's going on. We got to do an ultrasound or do some kind of x-ray to see if it's cancerous, it's solid, or whatnot. We also have something called an Wig Sarcoma. Sarcoma, again, malignant. We usually see this in children, usually between 10 and 15 years old, but it can happen before and after that. All right. This is a cancer that we see solely in Caucasians. Very, very rarely in the black population, but we see it mainly in the white population. And then we also have multiple myeloma, which we've talked about before. This is a malignant cancer of the plasma cells. And if you remember the plasma cells, they make antibodies. All right, the Bench-Jones proteins, if you remember that, that's what this is from. Okay? So this came from your book, and it gives you some idea of where these are occurring. And there's a few bullet points that you should note over here, which is what I repeated, like Ewing sarcoma, 10 to 15 and so. All right, questions about that? Not too bad, right? All right, so let me do some joint disorders for you. Arthritis. There's a lot of forms of arthritis. When someone says I have arthritis, it doesn't, in the layman terminology, everybody understands that, but you're going into the medical field, so there's a lot of different ones. I'm going to talk about osteoarthritis, rheumatoid arthritis, and gout, but there's other ones too that infections can cause. We're not going to get into those. So we have osteoarthritis. Osteoarthritis, if you remember, if we have a bone over here, let's say this is your femur, and then you have your tibia over here, at the ends of these bones, you have cartilage. The cartilage is there because cartilage doesn't have any nerves. So think about it. If I weigh, let's say, 120 pounds from my waist up, give or take 50 pounds, but let's say I weigh 120 pounds over here. I'm putting a lot of pressure as I walk onto my knee area, right? Now, that should cause a lot of pain if I do that all day long. When we have cartilage over there, there's no nerves in there, so the pressure on the cartilage doesn't feel any pain. That's why we can keep on walking and no issues. Now, when you use them more and more throughout your life, you're going to start wearing down on that cartilage, so that there's going to be areas of exposed bone in those areas. Now, when there's bone to bone, that will hurt because bones have blood vessels and nerves and so forth. Okay? And you're going to start grinding down the bone. We call it crepitus. And you can actually feel it. So bone to bone, you can feel when you start bending your knee. But what happens here is that when these start wearing down the bone over here, the osteoblasts say, whoa, we're getting thinner and thinner. So osteoblasts say, we've got to start putting more calcium in here and start building bone because we're making it too thin. The problem is, as you're walking, there's not a time where there's some rest. So these osteoblasts start building and building, but they go in all different directions because it has no, if you let it rest for 6 to 8 weeks, but who does that? 6 to 8 weeks, it may grow in a systematic way. But you're always moving, so there's no time for it to go in a systematic way. So what happens is it starts building these erratical, or let's say these irregular areas. These are called osteophytes. It's on the next slide. Osteophytes, or what laymen call spurs. Now you have these areas here that, depending on which way they're going, as you try to bend your knee, you can't bend it all the way because there's a spur that's trying to block the other spur from going. So you have a decreased range of motion because of these spurs. Can you actually file these down? Sure, but they're going to grow right back in a different way. Okay? So that's what's happening with that. So osteoarthritis is a degenerative disease. Okay? This is what you're thinking about someone who's, let's say, 50 years old, having arthritis in their fingers or their knees. That's what we're talking about. Okay? So they have the pain, deformity of the joints. They have these osteophytes start forming in, let's say, in the fingers, if there's arthritis, osteoarthritis in the fingers, and they're known as Hetherdon's nodes, or also Burchard's nodes. I'm going to show you pictures of what that is. The crepitus I talked to you about, that grinding sound where it's bone to bone, and the osteophyte, which is the spurs that I was talking about. The treatments for these is usually just going to be, it depends on the severity. Start off with just giving up analgesics, like for painkillers. You guys know what NSAIDs are, right? Non-steroidal anti-inflammatories, things like ibuprofen, aspirin, those kinds of things. If that doesn't work, then they go to corticosteroids. See, what happens with this builds an inflammation. And there's a lot of fluid that starts building up here. And you need to cut down on the inflammation because that's what's also causing pain. So you could also give corticosteroid injections. Steroids actually decrease the immune system. That's how it works, right? So you can do that. And worst case scenario, you just do a joint replacement, which is surgery, but we try to do the medicinal way of doing it first. So this is just showing you all this white area here is cartilage, right? This is your femur, and here's your tibia, kind of like what I just showed you here. The white area is the cartilage, and then you can also see the spaces that it's going to be bone to bone, so from here to here, and you can even see some bone spurs over here forming. That's osteoarthritis. If they don't know what's going on, they can put they can put a scope inside the joint, and they can see what's going on over here. The problem is we can't make cartilage grow. You can't make it grow. There's no blood vessels there. So what they'll end up doing is that they're going to have to do, if it's so bad, we'll have to do like hip replacements or knee replacements for that matter, like this. It's just too far gone over here that they're going to put the piece of metal over here, and they put a piece of plastic to take the place of the cartilage. All right, that's what a hip or knee replacement is. Okay, rheumatoid arthritis, different kind of arthritis. This is going to be more of an autoimmune disease. You're making antibodies to fight against your joints. That's what's happening over here. Okay. Females have it more than males, as in any other autoimmune disease. Okay. And it's usually, we also refer to it as juvenile onset arthritis, because usually this is much early on that you would get this. Maybe 15 years old, maybe 25 years old, 30. But the osteoarthritis I was talking about, a wear and tear, so you got to be using your joints all along, so it's usually like 50 years old and higher. Okay? And they have these lifetime flare-ups as any autoimmune disease where it's bad for, let's say, 2 months, and it gets better for 6 months, and then it goes away, and it goes back and forth. You have these flare-ups, okay? So some other things, if they have it in their hands, their fingers, if they ask them to point their fingers, they kind of have this zigzag kind of, I'll show you pictures of it, zigzag kind of trajectory of their fingers. Like we call Boutonniere Deformity or swan neck. I'll show you, it'll make sense. They also get these nodules. We see it a lot on the elbows in the areas there, and I'll show you pictures. Okay. Basically, the treatment is very similar to osteoarthritis. However, there's a few other things that they could try. So you can do the analgesics, NSAIDs. They have this new thing now for the past 10 years or so, these biologics. And it's not just for here, it's for other autoimmune diseases. But biologics is basically certain kind of medications that we use to block certain areas of the immune system. If your immune system is making antibodies to attack yourself, well, let's try and block that immune system from doing that. There are a lot of side effects because you block the immune system, you're also more prone to getting other infections, right? So, so they have biologics, corticosteroids, there's methotrexate. Gold salts is another one. I don't want to ask you about this over here, but gold salts, if you ever see a question on gold salts, you're thinking rheumatoid arthritis. Gold salts, we don't understand the mechanism, but if you infuse that in someone who has rheumatoid arthritis, they tend to get a little bit better. The problem is there's two issues about gold salts. One, it's very expensive. It's gold, and you're infusing it in them, okay? So it's very expensive. The second thing is these gold salts get clogged in the kidneys and cause kidney disease. So if they're going to do gold salts, it's like a last resort for so many reasons, okay? But if you see a question and you see, not on mine, but I mean in the future, you see someone who's got arthritis and the doctor is, or the nurse practitioner is considering gold salts, those clues, bring like a highlighter, those little clues, gold salts, arthritis, it's rheumatoid arthritis. You could almost guess the question they're gonna, or the answer they're asking for. There's these little pearls to help you along with that. So this is just showing a normal joint. Here's rheumatoid arthritis. Here's osteoarthritis. But let's look at these other pictures here. There's osteoarthritis, and you can see these Heberden's nodes I was telling you about in the fingers. Over here, you see how they like a zigzag kind of formation of the fingers. Okay? If you look at the x-rays, you also see that, and this is something you should notice too. In osteoarthritis, it's usually the distal phalangeal joints that usually get malformed. In here, in the rheumatoid arthritis, it's usually the ones that are the metacarpal proximal phalange ones that are actually causing more of the deformities. Okay? If you look up here, they're pretty straight, the distal phalanges. All right? So it's more proximal with the rheumatoid arthritis. As I mentioned here, and the distal ones are usually the osteo. Again, that's what it looks like. You see the Heberden's nodes over here. And again, look at the fingers. They're like bending. Okay? There's more Heberden's nodes. You can see that on there. More over there. And this rheumatoid arthritis, you see how it gives you that zigzag? It's called a swan neck and Boutonniere's deformity. So you get some idea what that person has over there. Okay? And those are those rheumatoid nodules I was telling you about. Those are pretty severe ones, but that's how big they get. So let's talk about gout really quickly, okay? Gout is a metabolic disease, okay? And it means that there's high levels of uric acid. See, little clues. You see someone has arthritis, uric acid is up. You really don't need, I mean, you can read the rest of the question, but you know what they're going to be asking. Those little clues. So high levels of uric acid, okay? You have too much, the kidney is overwhelmed with all this uric acid, so it starts accumulating in the kidney and forming stones. The stones are not like kidney stones, like these, they are kidney stones, but kidney stones can be made of different things. If someone has hyperparathyroidism, this is somebody that has a lot of calcium in their blood, well, the kidneys are overwhelmed with all this calcium, and it forms kidney stones, and if you bring it, you send those stones to the lab is going to break it all up and realize it's calcium. If they find out that there's uric acid in there, then they know the cause is because of gout. So don't think that all kidney stones are made of the same stuff. You need to collect them and do a laboratory analysis to figure out what type of material's in there. Now, what happens here is that you have uric acid not only just overwhelming the kidney, but it's all over your body. And it starts going into soft tissues. It leaks out of the blood and goes into your soft tissues, muscles and connective tissue. And it starts building up. If it starts building up and you can start seeing it, I've seen it in the ear, we call it a tophus or many tophi. But one place that it's about 90% of cases, it goes right to the great toe. Someone's got great, pain in the great toe, and he has kidney stones. You're putting things together here. Could be gout, you know what I'm saying? So we call that a podagra. Podagra is where the great toe is actually affected by the gout. Okay, and it's very painful. They get the kidney stones, and the area becomes very red, and that's what it looks like. All right, there's a finger over here. There's a podagra of the foot, and like I said, you see it also in the ear. So fractures and bone repair. This is what doctors usually use for our symbol for fracture. This tic-tac-toe board. You young ones over here call it a hashtag. I don't even know what a hashtag is. All right, but we see that, especially for radiography, doctor might say rule out hashtag. He's not trying to put you on Instagram or anything like that, but that's what that is. All right. So it's any kind of crack or break that's due to some kind of extreme mechanical stress. Most will heal, with we'll put a cast around it, and most will heal well, as long as you have the blood supply going over there. Now, there's some fractures which I don't want to go into. But there's certain fractures that might have only one blood supply going to that bone. Like a scaphoid is a good example, which is part of your carpal bones. If you kink that blood vessel, then that's not going to get blood supply to that scaphoid area if that was what was cracked or fractured. So it has to be put in a certain kind of formation in a cast so that the blood supply won't be compromised. So that's why it's always important when you're putting casts on that there's certain ways you got to put them on and all. All right. So as long as the blood vessels are not going to be compromised, they will heal quite well. Okay. Cartilage, on the other hand, not good. All right. There's no blood supply there. All right. So there's two major categories of fractures. It either breaks the skin or it doesn't break the skin. If it doesn't break the skin, then we call it a closed or simple fracture. If it does break the skin, then we call it an open or a compound fracture. Those are more deadly. A lot more blood loss occurs there, obviously, and also you just puncture the skin, and now you've got the medullary cavity open, which is where blood cells are. So now you have bacteria that's on the skin that's able to go in. You just created a window so that bacteria can come inside the body. So those are what we're concerned about with open or compound fractures. So we're just showing you closed fractures here, open fractures over here, breaking the skin. There's a lot of different forms of fractures that we have, a lot of different types. A transverse fracture is just, if this is the bone over here, that's a clean cut, straight back, straight down. A transverse, okay? Then we could also have a spiral. That's kind of difficult for me to draw like this, but think of it as a fracture that kind of goes this way and then around on the other side, fracture like that. You know, it's like a twisting kind of thing. It's going to go around there. Then we have a displaced fracture, and a displaced fracture, this is that. Maybe that way. Now, it might, this displaced fracture, it's not to put it back the way it was. This might break the skin, it might not. So we could have a closed or a compound displaced fracture, okay? So here's a spiral one. You can see it over here. It's like cracked over here and then going this way. I'll show you another picture in a little bit. Okay. A compression fracture we see with older women going past menopause is a good example of this, although that's not the only time we'll see it. The vertebrae, since there's a lot of osteoporosis that happens in the elderly, what happens is they become more like styrofoam, the vertebra. So as the pressure goes on there, it kind of crushes the vertebrae. It compresses the vertebrae. And that's the reason why grandma gets smaller. All right, she gets shorter because of these compression fractures in the vertebrae. Okay. Greenstick fracture, we usually see it in children, and the best way I can explain it, you ever take like a branch from a small twig that came off of a tree, so it's really fresh, and you break it, but it's still attached by the bark, all right? It's kind of doing this thing. See how it's still attached to one side over there? All right. So that's what, I mean, you should see it, I'm not too sure why, but we see it more common in children, a greenstick fracture. Not sure why they even call it greenstick, but that's what they do. But it's where the one side is still attached, but it's kind of broken off. And it's basically take a twig and break it. It's still attached on one side. It's a fresh twig. That's what that is. A comminuted fracture, it's in pieces. It's shattered. Okay, there's pieces all in there. All right, that's the one that's going to need a lot of screws and plates and things like that. Okay. So here's a Greenstick Fracture, kind of like what I drew for you. You see over here, it's attached here, but you can see the break over here. You see that? Okay. That's a comminuted fracture. It's all in pieces. Okay. You have the epiphyseal fracture. Those are pretty bad. Okay, not that these aren't, but this is pretty bad, especially if it's in a young one, a child or an adolescent. This is where we're having a fracture that actually goes through the epiphyseal plate also, so it extends into there. So now it's going to interfere with the growth lengthwise of that bone. It might not occur. So now it happens in one leg bone, but not in the other one. So now one leg bone is going to grow faster than the other one, and they're going to be like this. And that can actually cause like scoliosis, the curvature of the back. So this is one we take seriously. And what they end up doing with this, when I went for physical therapy for my own knee, I talked with I guess he was about like 14, 15 years old, and he had one of these. And I'll show you a sort of picture afterwards. But there's this metal ring, a couple of metal rings that go around the leg itself, and there's pins that go from the ring into, well, I'll just show you in a way. This is a very schematic view of this. Here's the epiphyseal plate over here. So technically, this is going to go outside the bone, so outside the leg actually. You have this kind of ring that kind of goes around here, and there's going to be a pin here and a pin over here. Basically a pin here and a pin here. And then there's a little, I hate to use this word, but that's what he called it, a crank. And every 2 or 3 days, the doctor has to turn this crank, and it makes this go that way and this way for about 1 millimeter every 3 days. I don't know the exact measurements, but it's that. And the kid told me it's the most painful thing he's ever heard or ever felt, because it's that you're pulling the bone apart to create the actual bone to grow. So they got to do this. Right? So that's an epiphyseal fracture. Not so worrisome in, let's say, an adult, but during the child or adolescent, you've got to be pretty aggressive with the treatment on this. Okay? A Potts fracture, there's 2 leg bones that are in our shin area, something called the tibia and fibula. If both of those get fractured at the distal end, we call it a Potts fracture. We also have a Colles fracture, and this is where we have 2 bones in our forearm. And if the radius at the distal end breaks in a certain way, we call it a Colles fracture. You could look at the hand and the wrist, and you could see if it's a Colles fracture or not. The history will tell you a little bit. It's usually, here's a typical case. A woman, it's in the winter, and she goes on ice, and she slips and falls, and she extends her arm to try and break her fall, so that she'll land on her arm. And what happens is, when she lands on the ice, it kind of pushes this, and now you just fractured the wrist. They have like this dinner fork deformity. What's happening here, a Colles fracture is where the radius fractures here. There's another one called Smith's fracture. Don't worry about that one. But here, it kind of fractures here, and it creates this dinner fork. If you look at the side of a fork, it has a, you know what I'm saying? And you can look at the hand, and you can almost see that's a Colles fracture. Does that make sense? This has to be positioned in a certain way in a cast so that it heals properly. But you can look at this, and he says, oh yeah, I feel like I can look at this and say, I know what kind of fracture that is. Okay? It's just this classic dinner fork. Do you know what I'm talking about with dinner fork? Not 4 prongs, but the side view of it, right? All right, so that's a dinner fork deformity. All right, and these are just different forms of the different types that we kind of mentioned on the fractures. Okay, and there's what they look like X-rays.